Hi Pratik,
Hi Divya.
how are you? Pratik, are we losing you? I can't. Hi Pratik, you there? Oh, we lost. Hi Ronak. Ronak, you there? Yes, Pratik, we are back.
Yeah. All right. Sorry, I was not audible. मेरे ख्याल से कुछ issue हुआ था मेरे end पे. Am I audible right now, Divya? Can
Yes,
you hear
yes,
me?
perfect. Loud and clear.
Loud and clear. Great.
Yeah. Hi Ronak.
Hi Divya, hi Pratik.
Hi Ronak. Thanks for
How's
joining in.
everyone? Nikhil has
Hey
also joined.
Nikhil.
Hi, welcome.
सब बढ़िया है यार, सब मस्ती में संडे बना के लौट रहे हैं और मैं राउंड लेकर लौट रहा हूँ।
Oh, good, good. All well? Patients are all doing fine?
हाँ, अभी तक तो सब अच्छे ही है, डिस्चार्ज का ही प्लान है सबका।
Good, good. Peaceful
और
weekend.
यस यस, वेरी पीसफुल वीकेंड, थैंकफुली, टच वुड, यस। अभी भी संडे बाकी है, अभी रात बाकी है। ये आर्टरी वाटरी वाले सब रात में ही आते हैं।
Hi
Yes.
Nikhil.
Actually, Saturday evening is the time when like worst patients enter. ऐसे Saturday evening तो कुछ
सही
cursed ही
बात है।
एकदम jinxed है
हाँ,
वो.
सैटरडे अगर थोड़ा कूल निकला तो एक अंदेशा रहता है कि भाई संडे निकल जाएगा।
Correct, correct. Hi, Nikhil. आप muted
निखिल ने
हैं.
प्रतीक की बातें सुनेंगे। प्रतीक क्या बताएगा आज? अच्छा अच्छा बताएगा।
Yes, very useful.
कोशिश तो करेंगे यार.
नहीं, सही है यार, पेरेंट्स के साथ रह रहे हैं, पेरेंट्स इन लॉज सबका हो रहा है। अब दादी दादा तो रहे नहीं, पर एल्डरली केयर इज वन थिंग विच आई मतलब आई तो रेगुलरली सी बेड सोर्स और वो वाले, मतलब खूब सारे एल्डरली विद पेरिफेरल न्यूरोपैथीज, ये सब बातें ही रहते हैं। और आधे टाइम तो उनको बस बात भी कर लो, उसमें काफी अच्छे लगते हैं। और कुछ
Yeah.
चीजें जिनका तो अपने पास मेडिकली है ही नहीं, जो न्यूरोपैथी हो रही है वो तो अब होती ही जाएगी, कितना B12 खिला लो।
Correct. Correct.
And this problem is worsening day by day, like especially with CKDs. Like abhi we are the prevalence of
सही बात है।
pediatric population coming with chronic diseases now it's going up day by day. So it's high time we pay due attention to this.
दूसरा बात, जेरियाट्रिक का मतलब फिजिशियंस भी ऐसे ट्रीट करते हैं, मतलब कि नाउ तो इट्स ओके कि
Yeah.
भाई
Yeah.
अब
Yeah, yeah.
इतना हो गया।
There's a
मतलब
term for it. There's a
Therapeutic
therapeutic
nihilism.
nihilism.
Therapeutic
Yeah.
nihilism is what it's called. Yeah,
So
Therapeutic
especially
what?
nihilism. So therapeutic nihilism is there. Like suppose
Oh,
if 75-year-old person gets an MI versus
Hmm.
50-year-old gets an MI. So
सही
our
बात.
attitude same with kidney failure. If 75-year needs
Hmm.
dialysis versus 40-year-old needs dialysis. So
सही
same
बात.
kidney biopsies or all invasive procedures. So there is a nihilism towards them in therapeutic procedures. So chalo, I guess it's 7:02. I think we should start. Nikhil has some problem with the microphone. I hope it gets solved in time. I think you can hear us, right, Nikhil? Can you hear us? Great, great.
superb.
So till the time you can hear Pratik, everything is sorted.
कौन
बाकी
से
कुछ
हाउस
भी
में कर
फर्क
देते
नहीं
हैं?
पड़ेगा. Yeah.
बाहर.
So
चलो शुरू करो. Yes, yes.
yes, I think we should start because we should stick to time. Yeah.
Yes.
So, welcome everyone. It's a pleasant Sunday evening, and we have a very, very special program for to end your weekend in a very informative way. And here we are with our very own uh, psychiatrist, mental health specialist, everything related to mental health of this group. He has kindly agreed to help us today to walk through, to hold our hands and take us through this very, very difficult topic, which many of us think about, but we don't have the courage, or we don't have maybe the time to discuss it out in open, and that is geriatric mental health. So I would say just because I thought of moderating this, I was going through the epidemiology and all. So currently geriatric population makes around 10 to 15% of our total population in India, and it's
Yeah,
very steadily rising. By
yeah.
2050 it will go up to 25 to 26%, which is
And
like
it
a
will
very,
include us. And
yeah.
it will include us, all of us.
Yeah. Eventually it will definitely include all of us. And there's this very famous saying that India is growing old before it gets rich. So our fertility rate has declined. It has now declined to below replacement level. It has become 1.9 now. So we will be a old population very soon. So, Pratik, I really want to know from you in your practice or from literature which you are going through the evidence, whether problems related to mental health are also growing the way geriatric population is growing. What do you think about that?
Yeah, I think mental health issues have been raging in all age groups. Right now, hopefully, we are doing awareness really well, and populations, right from the geriatric and to the pediatric spectrum. I think if we sit down to talk to people as to how they are doing subjectively, there are a host of mental health issues that they'll let us know, and everyone has been given a list of worries, I'm sure. So what we have seen in the clinics is by the end of the age spectrum, there are various mental health ailments that increase in their incidence. Memory issues are just one of them, but the most commonest are depression, anxiety, sleep issues, somatic complaints. So these are what we call as medically unexplained physical symptoms. So these are pains and aches and somatic symptoms which are resistant to NSAIDs or other painkillers, and they have their origin somewhere in the mental health realm. So this is the spectrum that we see. This is the kind of issues that we are seeing in our clinics these days.
Yeah, very, very true. Actually, they are increasing with everything else increasing. Similarly, all
True.
non-communicable chronic diseases are increasing in that age group, and
Yeah.
with this also. So, just for everyone's sake, I wanted to formally introduce Pratik. Like I asked for a CV or a formal introduction, and he was just like, no, no, not needed. And that's true because we all of us know him very well. But I really want to point out that he has authored a very nice newspaper article about aging and dementia, and he mainly practices adult psychiatry, but he has a very special interest in geriatric psychiatry. So we could not have a better person than him to enlighten us today. So now, Pratik, tell me that like you we are talking about aging. So there is something normal aging, like some things are normal with age, and then
Yeah.
there are some signs or symptoms which you as a psychiatrist might find out of that normal two standard deviation. So what are the changes which are there in a person who ages normally, and then what are some danger signs which we should be looking at?
Right, right. But to begin the discussion, I would just want to, bring everybody's attention to this one fact. Modi, Putin, Xi Jinping, Trump, all of them are above 70s. So it's not a bad age group to be in, and people can still aspire high, politically or anything else in their lives. But yeah, coming back to the topic at hand, I would say our seniors are libraries, as in they are unmatched in their wisdom and the information that they hold for us. Um, in normal aging, there is of course 20% loss of brain volume and brain weight. By the age of 85, that dendritic network will become very sparse. So there are certain changes. Even in scans, we can see what they call as white matter hyperintensities or periventricular white matter changes, which can signify microvascular or small vessel disease. Generally, this is something which is amplified as they age. Taking the autopsy sample of the brain, we might just see senile plaques, neurofibrillary tangles, and so on and so forth. But they don't signify necessarily the process of dementia, but they are present in the aging brain. Successful aging is a term where we see that there are three meanings to it. One is there is avoidance of disease related disability, as in the person is relatively healthy. There hasn't been any loss of function because of any disease process. Second is the presence of normal physical and cognitive functioning. So the person can move around, the person has good bladder bowel function, the person has memory, attention span, which is like appropriate to their age group, and active engagement in life. That's the third one. So active engagement in life is having a great interpersonal relationship and bond with people around them. So for successful aging, I think the Indian system that we had earlier of joint family was very useful once. But yeah, economically not viable. So right now we find nuclear family is much more prevalent. The things which happen in the geriatric age group, which are very worrisome and which cause hindrance in their independent functioning, is changes in the prefrontal cortex. Basically, everything that in mental health has a diagnosis, the seat of it all lies in the prefrontal cortex. So the problem that we see there in our senior citizens is something called as executive dysfunctioning, as in there are certain aspects of our brain, mainly planning, organizing, impulse control, inhibiting abnormal impulses, working memory. All of these are somehow taxed as our brain ages. And executive functioning has four components. Number one is called volition, meaning it's an ability to act intentionally. It's an ability that the person can do some task. Second is planning. Planning is basically having a step wise approach to a problem. Then there is purposive action, which is basically we taking an activity and doing it. And the last is called effective performance. Basically, this is something where we can monitor our way of working, and we can draw out conclusions based on what we have done, what we have performed, and we can keep refining our performance. All of these are somehow, to certain extent damaged because of the aging process. Now, uh, as you mentioned, non-communicable diseases, diabetes mellitus, hypertension are one of the leading causes of small vessel disease, and we are seeing that dementia onset has been very soon in people with these kind of ailments. And if dementia earlier would be by the age, we would be looking for it by the age of 65 plus. Right now it has come maybe in the late 50s till early 60s as well. We are not handling our stresses really well. And at the same time, people are not really active in their lifestyles. So all of these somewhere alongside with the aging process has given rise to unfortunate circumstances. So this is basically the whole gamut of what we see as changes. Now, psychologically, in these individuals, what is supposed to happen at the age of 65 plus, that they are supposed to be independent of their responsibilities, and they should have passed the baton on to the next generation. Now, when they have done their jobs all okay, they are generally not very bitter people, as in उनके घर में बॉल गया तो वो बॉल देने आ जाते हैं. They are not the people who will be spoiling somebody's Sunday mood. But the thing is that they start what we call as the spiritual journey of finding out why they are on this earth, what is their purpose of existence. It is a search that psychologically starts at that age group. Now, unfortunately, this population also is prone to isolation, also prone to some amount of vulnerability because of their medical comorbidities. And we see that support, when it is coming through NGOs, when it's coming through families, is a very good way to care for our elderly. So yeah, Divya, back to you.
Yeah, yeah. Very interesting. Actually, I really like the term which you said, successful aging. So that's a very I have heard for it for the first time, and I am really very happy that there's a term like that. So that is what our if all of us should aim for. So I would just like to share my experience with my nani. So she was there till a few years back, 3 years back, and she was 93 when she left us. And like this successful aging like absolutely fitted her
Yeah.
description very well, so much so that she would see all those daily soaps, and she would remember all the characters, all everything which has happened 200 episodes pehle. And I was feeling ki I have more dementia than or memory loss than what she has. So moving on, so one of my problems with my nani, like when after she was 85 plus, was that her hearing ability went down,
Yes.
and
Yeah.
so does vision. So she could still see TV soaps and all, but once this hearing and vision goes down, like the sense organs are going down, they get very alienated, like very lonely they become,
Yes.
because they are
Yeah.
not able to communicate. Even though we really want to include them in discussions, we
Yeah.
want them to be a part of our lives, but because of
Yeah.
this barrier of not able to hear or not able to read, maybe because like she was a teacher professor, but then eyes are
Yeah.
not there, so she can't read. So
Yeah.
when this starts, so I want to know from you that how to overcome this when their sense organs are not helping, how we can still make them a part of our family, and let them feel that they are not alone or alienated. So what
Correct.
we can do there?
So, like I said earlier, there was a joint family system, and right now there is a nuclear family. But having said that, this exists in cities. I've seen Gujarati and Jain families having great support systems towards their elderly, as in they have huge families, and there is someone or the other who comes to help with the elderly person. Now, um, a general physician, a psychiatrist, a neurologist, an occupational therapist, and a speech and language pathologist. Ideally, they form the proper team for caring for a geriatric age group person. Now, the general physician, if they are looking for certain ailments, so uh, if I am receiving any senior citizen with any emotional issues, There are a host of examinations that we have them go through, including imaging and blood investigations. But yeah, what happens with aging is a sensory neural healing loss, and the chances of any visual impairment like cataract commonly, but at the same time corneal opacities or retinopathy because of diabetes or hypertension can hinder the quality of life. The functional uh, the functionality of that person is somehow affected. So we, as mental health professionals, also look out for the hearing acuity and the visual acuity. Having said that, maintain this one stance towards my patients, that they have to undergo some amount of assessments for the sense organs, because that is something which makes my life easier, makes my treatment successful, and at the same time they get reconnected back to their caregivers. And very recently, and he'll not like it if I say this, but yeah, I got my father his first hearing aid, and I took him for an assessment because he would not listen to whatever I'm saying properly, and he would not be able to listen to high pitched voices as well. So it was good for him, but because my mom's voice is very high pitched, but but the way things are with regards to hearing aids, I think the sensory deprivation which happens because of not having the proper conduction, or the conduction of sound mainly, can cause dementia, can cause cortical changes, specifically auditory cortex. But it's a sign of aging getting complicated by blindness or by hearing impairment. But the whole team has to look for it, and I work with general physicians, I work with neurologists, and we make sure that we check out other signs and symptoms for the impairment that the senior citizen is going through.
Yeah, very, very important insight. The team effort is very important. So while we are at dementia, I want you to clarify two terms for me. One is dementia and one is pseudo dementia. And
Yeah,
also, at least in my practice, I see a lot of delirium. This
yeah,
elderly people, their sodium becomes 125, 120, 119, and then once it drops below 120, they come with delirium. And this lots of I'm telling from nephro perspective that like a hyponatremia, but similar to hyponatremia, there are many non-communicable common chronic diseases
yeah.
which have this delirium, which doesn't come today, like out of sudden acute. They can be
Yeah.
very slow, chronic, progressive. So I want you to also elaborate on how to differentiate between these, very important, because the treatment is completely different, and even the
Yes,
investigation. So,
yes.
dementia, pseudo dementia, and delirium. I want you to break this, all of this for
Right.
us.
Right, right. So, in psychiatry, we have a caveat which says untreated anxiety might progress into Parkinson's. Untreated depression might progress into dementia. So, depression is also called a pseudo dementia because it also has memory impairments. What is the simple definition for dementia? Any memory loss or memory impairment causing a hindrance in a daily routine activity. Now, daily routine activities can be personal activities of daily living, like bathing, clothing, eating food, managing medications, taking a bath, getting out of bed, transporting or moving about independently. They can be instrumental activities of daily living, can be about managing smaller finances of self or the household, operating gadgets like remote controls or mobile phones, can be about just about doing some mental math. But generally memory impairment leading to disruption and requiring the person to be dependent on their caregivers is called dementia. Delirium is a picture, what we earlier used to call as ICU psychosis, wherein the person has clouding of consciousness, but The problem mainly in delirium is attention. So the attention span, they cannot focus or shift or sustain attention, and there is altered sensorium, like we see in them. There are various causes of delirium, and metabolic causes, are, I think, the most important ones in the elderly. And there are host of other medications that they are on, commonly loop diuretics, or any oral hypoglycemics, or antihypertensives, which can cause some electrolyte imbalance, or can give rise to hypoglycemia, and can precipitate a delirium like picture. Delirium, having said that, is a medical emergency and has to be treated in a ICU setup. But what we require in delirium would be an orientation of the person towards the time of the day, basically. Because in an ICU setup, unless and until there is some amount of environmental cueing, meaning where they have an access to a window, and they can see what time of the day it is, what is the date on the newspaper, what is happening in the outside world, their relatives are by their sides seeing them. We can definitely prevent delirium. Now, I've taken delirium apart because I wanted to compare between pseudodementia and dementia. Pseudodementia and dementia, having said that, like depression is the main cause of pseudodementia, meaning the person has memory impairments, but there is no functional impairment. The person is still functional in pseudodementia. And dementia usually won't be so much, and there are certain behaviors which characterize dementia. Now, a person with dementia, their family are often unaware of what the dysfunction is, or how much is the severity of memory impairment. As opposed to that, a person with depression would glorify their dysfunction and severity, and sometimes a person with dementia might not understand the onset of memory impairment, but a person with depression or pseudodementia will say that, okay, it's since May 2024 that I have been forgetting these things, or this is my memory impairment. And there can be any limits which a person with dementia can give us, but it can be given by a person with depression. There are times where the progression of symptoms in dementia are very slow progression, but in depression it is rapidly progressive. And after the onset of depression, if untreated, we see that the memory impairment, and the testing of it all gives rise to a peculiar kind of result. So, coming to the testing of the cognitive loss, generally, a person with dementia does not complain of cognitive loss. They would never say that I have memory impairment. They would try and hide. They would they would struggle to perform in the memory testing tasks, and at the same time they will conceal their disability. On the other side, a person with pseudodementia will complain much of even a slight bit of cognitive loss. They would generally emphasize their disability, they would highlight their failures, they would give a lot of distress about what is happening to them, as opposed to a person with dementia who would really, really work to mask off it all. The social skills, sometimes in dementia, are very well retained, but in depression, in pseudodementia, there is loss of social skills that we see. um, and the one mental faculty which is very impaired for the senior citizens more than memory is attention span. And even if we do a mini mental status examination, we have, which is a bedside test, or a clinic test which I have administered to all my patients, we have to test attention prior to memory. So, generally, what we see in our patients is attention and concentration is very well preserved in a person with pseudodementia, but attention and concentration in a person with dementia, on the other hand, is very faulty. They give a near miss answers. The person with dementia would give near miss answers, and a person with depression will generally stick with don't know. That's what they'll say. And there are memory gaps for specific periods which a person with pseudo dementia would give, but the memory gaps for specific periods is unusual in a person with dementia. So These are some differences that we can see in the course, the clinical course, and the testing behavior, and the clinical features, or the intellectual dysfunctions in a person with pseudo dementia and dementia.
Thanks, Pratik. That was a really exhaustive list, and it is so important to differentiate between these two conditions from early on because, like you said, pseudo dementia is depression, and the test which we'll be doing and the treatment will be completely different from
Different.
dementia, where we'll be
Yes,
focusing more on the causes of dementia and also
correct.
delirium. Because, like I'm a nephrologist, I get, you'll not believe, I had a patient with recurrent urinary tract infections and a very
Right.
elderly lady, 80 plus, and a little bit of hyponatremia. I see a lot of hyponatremia related. Hyponatremia
Yeah.
can cause anything under the sun,
Anything. Yeah,
but
yeah.
urinary tract infection was misdiagnosed as a psychiatric illness for almost a year. Imagine. And she was just referred from neurologist to psychiatrist and back to neurologist, and she was only roaming around everywhere. And once we treated her UTIs and everything, with age, the way these illnesses express themselves also
Yeah, yeah,
changes. So
yeah.
we should look out for every possible medical cause
Yeah.
also in
Uh,
these
I just wanted to emphasize one more thing. It is nice to kind of talk to our senior citizens about how they have been feeling about life. I'll tell you why the chances of a completed suicide, as in suicide leading to death, the chances of them are very high in the elderly. They are somehow, there might be a death of a spouse, which is the most stressful event in a person's life. They might be feeling unattached. They might be feeling that, okay, right now, I think I am free of all kind of, uh, you know,
responsibilities.
responsibilities, and nothing in my life is dependent on me right now. So they are very happy and elated sometimes just prior to committing that act. So we need to be looking out for our senior citizens and specifically screening them for depression or pseudo dementia.
Very, very important. And we have Neha, Atish, and one more friend who's using OnePlus have joined us. So, welcome everyone.
Right.
Please feel free to type your questions, or if you want the need to be unmuted, please feel free to do that as we go through this very important discussion. So, we were at pseudo dementia and dementia, and you told us that how depression can be misdiagnosed as dementia, called as pseudo
Dementia.
dementia. So I want to probe further into this depression in elderly. Is it how different it is from depression in young people, and what are, whether the some signs are different, and what can be done? Whether you would straight away go for antidepressants, or you would wait and give some behavioral therapy first, and how the approach is different from young patient with major depressive disorder.
Yeah, I think Nikhil, you can unmute yourself. There's a question I think he wanted to ask.
Yeah, hi
Uh,
Nikhil.
can't hear you, Nikhil. Hi. Just yeah.
Oh, sorry, still can't hear you. Maybe you can type the question in the chat
Yeah,
box, whether
yeah,
that
if
will
you
help.
can.
Yeah.
In the meanwhile, Diva, you were asking about how do we go about diagnosing depression. Now, we have manuals. One of them is called Diagnostic and Statistic Manual, that is DSM-5, which is having a text revision. That's the diagnostic manual that we use, and there is the other one, International Classification of Diseases, and it's in its 11th revision that we are using, these days. Uh, Neha also has a question. Okay, I have a challenge about
Yeah,
having older parents in another country, so hard to even gauge the right. Absolutely true. Right,
absolutely.
right,
Yeah.
and
Even
um,
that's not a country thing, Neha. We have even in India, like we have such a diverse Indian subcontinent. So if I
yeah,
am in Mumbai and my mother is in some small town of Madhya Pradesh, Chhattisgarh, so we are in the same boat. So Pratik, a
yeah.
very important question. Tell us.
So our seniors are just a kind of extension of us. Like whoever is an adult right now, Our seniors are just like us, and they are only altered in their, like the way their liver and their neurochemistry might just be, or their kidney functioning might just be, but otherwise whatever criteria apply to us applies to them as well. So depression can be identified by two symptoms over the period of 2 weeks. Number one is persistent pervasive low mood, which the person can experience in all walks of life. That is number one criteria. Number two, decreased interest or decreased pleasure derived from previously pleasurable activities. And now, if any of these are happening for 2 weeks, that person can be diagnosed as a person with depression, and can undergo treatment. Also, I have to say this in every podcast that I've done about depression. This is about Deepika Padukone, and when she had come out saying that she had depression, she had given like a string of amazing performances, and her movies were doing well, but she just wasn't happy, or she couldn't say what was wrong with her, and she underwent treatments. She had the same thing. It's never only about suicidal thought processes. It's not a major criteria of depression. Sometimes it's just about anhedonia. Sometimes it's just about these kind of emotional issues causing a disruption in daily routine activities. There are other minor criteria of depression as well. Increased or decreased sleep duration, increased or decreased appetite, idea of guilt. There are super guilty ideations that sometimes our senior citizens have, mainly about how much their next generation has to care about them, the consultations, the medication cost, the various professionals roped into their care, managing all of them. Neha mentioned about being a person whose parents are here in India and she's in the States. I think even in the same country, in the same city, also goes through a lot of helplessness. Sometimes there's the communication gap that we see also leading to this. But coming to the minor criteria, increased sleep, or increased or decreased sleep, increased or decreased appetite, ideations of guilt. Sometimes there is what we call a psychomotor retardation, as in the thought process and the way these people move, that has become slow. Sometimes we see psychomotor agitation as well, as in these people have, inability to relax, and they are very agitated, very restless. Other minor criteria, of course, which happen sometimes with senior citizens with dementia. They have delusions of poverty. They have delusions of, say, even disability, to a point where they feel that, okay, there is loss of functioning that I'm experiencing, but we don't find any clinical signs and symptoms, but it is still there. Can be a sign and symptom of depression. And the last one, which is a minor criteria, not at all a major criteria, is suicidal ideations. Like I said, we need to identify depression in our elderly. There is a scale called as Geriatric Depression Scale. It's a 15 item. There is a short scale of called GDS, which has only 15 items, and it is basically asking the senior citizens as to how subjectively they feel throughout the day, as in whether there are any memory issues, quality of life, sleep, and appetite, how all of it is, taken care of by their caregivers. So screening depression is very easy in an elderly, but very important, because can be missed. We can attribute it to something else, but if we don't find anything, or if there is a person saying, I don't know how I feel, or I feel lost, or I just don't feel myself. What's the point of it all? I just feel that it would have been great that if didn't exist. I'm just so tired of my ailments these days. So these are certain proxy statements which a person with depression might make, and we need to be aware that, okay, this is a cry for help and we need to intervene.
So thanks, Prateek. So Sonal has joined us. Hi, Sonal.
Yeah.
Just for a recap of what we have gone through, we
Hi,
have discussed
Divya.
the
Thank you.
epidemiology. Hi, Sonal. So we have gone through the epidemiology. We know now what is pseudo dementia, what is dementia, how to differentiate them from delirium. We know what is successful aging and what are the danger signs, what we should look forward as our mental health of our elderly patients or family members is deteriorating. So now we can change gears, and we are 7:36. So now we okay before we change gears, so I was going to go to the caregiver perspective, but before that, Ronak has a very important question, that lots of us seniors, elderlies, though not uh, properly diagnosed with anything, they just have anxiety. Maybe it
Yeah.
stems from they are not able to do those things which they were able to do beautifully before, which
Before.
they used to excel, and now they feel
Yeah.
that they're lagging behind. Maybe like for my mother, it's just she's not able to cope up with the smartphone devices. So the simple things which we take it for
Absolutely.
granted, like we are so I'm like, how can you not book a
Yeah.
Uber ride? How is it that in 2025 you don't know how to book a taxi cab for yourself? So how do we and then then there is this anxiety, anger, and then there is this vicious cycle. So
Right.
how do we go about that, those behavioral changes which are there with age?
So, like I had mentioned early in our discussion about executive dysfunction, so there are these functionings of the brain in the prefrontal cortex which help us plan, organize, execute those plans, do impulse control, and monitor our performance and everything. Uh, like I said, with age that is being taxed. But we see our seniors who are getting anxious. Sometimes all they require is reassurance. Sometimes all they require is a supervised kind of a task. So I would have my mother screen share with me. Thanks to WhatsApp now the screen share is available. So I'll ask her to screen share with me while pausing my appointment with my patient, and I'll be telling her, okay, go there, do this, this is how you pay through Paytm, and your bank balance will not become zero, don't you worry. There are kind of uh, various measures which are taken for that. But with regards to anxiety, generally anxiety happens when thought processes are exactly about overestimating risk in a situation and underestimating resources. Now, when these kind of thought processes are there in our seniors, we really need to help them understand that there isn't much risk. We have to sometimes hold their hands because they have done that for us. We need to somehow now repay back, and holding hands can be done online. That can be done through any portal, but we need to guide them sometimes because it is a new technology, and even if it is made simple, it still causes a little bit of apprehension in their minds because the way the brain has changed in neurochemistry and the structure of it all. So reassurances and helping and supervising their tasks, never a bad thing. Always will be helpful in a person with anxiety.
Yeah, yeah, very, very important and very timely if we actually address them. It might prevent. It might actually help them in going into depression, because then they get anxious, they get angry, and then over the time, if they feel unsupported and
Yeah.
alienated, then they might the problems might worsen. So
Now, one more thing,
Faraz
Divya,
has
to add
joined
there.
us.
Just so sorry. One more thing to add
Yeah,
there. We all should do this in a very compassionate way, because
100%.
otherwise they'll get angry. That's it. Nothing more. Go ahead.
Yeah, I think we should remember when we were kids and the way they took care of us when we did
Right.
not know how to write or how to read, and the way they were patient with us. We need to be equally patient
Yeah.
with them now. So
Yeah. Yeah.
Faraz has joined. Welcome, Faraz. We are in the middle of a very interesting discussion, and we have covered dementia, depression, and also anxiety now. So now I think it's the time we move to the caregiver perspective, because we all are in that role. Like in not maybe not some people might not be having elderly living with them, but we are all in a sort of a caregiver role. And also when our patients come to us, they are also in this caregiver role many times. So I want to know that what is the burden, and how to tackle that? Is it, how do you successfully become a good caregiver?
Um, the first and the most important caveat there is to preserve one's own sanity. That's the most important. Your relative, your loved one will do as well as you are doing. That's the first thing that I always tell to my caregiver. And because caring for a elderly is a little bit challenging, because they are our elderly, they are someone who had taught something to us, but at the same time, right now they are in the dependent role. They are vulnerable, and they are dependent on us. So we need to devise newer ways of communicating with them to make things a bit easier for them as well. Like I said, sometimes people go through various kinds of difficulties. There might be isolation, there might be depression in the senior citizen, and it can be due to various ailments. It can be due to various social factors as well. So to reach them, and we need to be high on respect, and we need to understand that they have independence in their choices as well. We have to promote that. And when we come from a place of care and respect, we seldom lose out on the wavelength with with our elderly. Sometimes when we presume that it is easier for them, that is where we make a mistake. Sometimes we can just ask them, what is it exactly that you're struggling with, uh, just to cut through all the kind of confusion, and they'll let us know that, okay, this is something which I think I'm not able to do, and you can normalize the difficulty there. Yeah, it happens. I think this is the tricky one. And roll with the resistance, as they say, so that they get you exactly. It's more about the task as opposed to them. Make it more about the task, so that there is no much you don't step on any toes, and the person who you are helping understands that you are trying to help them, as opposed to critique their performance, which nobody really wants. There would be attitude issues there completely. So we need to respect that that they have independence, and we can ask them to perform the task in front of us to maybe help them out better. But respect is first. Second is teamwork. As a caregiver, identifying what the problem is firstly, what the issue with my senior citizen is, what the issue with my elderly is, and then who are the professionals who are supposed to care for this officially. The person, and the caregiver particularly is overwhelmed because nobody gives them a break in their routine life. So they are working, they are parents, they are bosses somewhere, and at the same time they are caregivers. So we everybody has to know their roles. Caregivers has to sometimes outsource the duties to another caretaker. So for a person with dementia, or maybe an ailing parent can be better cared for with a caretaker, with a general physician, with an internal medicine physician, a psychiatrist, a neurologist, if there are any such deficits. Having said that, this team will be responsible for the well-being of the person. So we need to also include sometimes a nutritionist as well to care for the nutritional needs, because there might be metabolic issues at play, and we need to care for that. Um, Third, that we need to do constantly is to have a routine. As an elderly, fixed routine of waking up and sleeping, then fixed routine of medications, fixed routines of activities, which include any activity which gives them stimulation. Can be even simple sudoku, chess, crossword, antakshari, karaoke. These are kind of activities which kind of spruce up their day, and these are activities where they interact with family members, and it is basically also like a good exercise for the caregiver, because they also indulge with their loved one in a task which helps them to bust their own stress as well. So we need to have a routine for everything. And the whole family has to take turns to care for the senior citizen. It just can't be that the lady of the house is taking care. The person has also got to, the male gender son also, or son-in-law, or whoever that might just be, also has to step in and needs to take care of the team and the routines of the person. We need to be prepared for any scenario. That's the fourth thing. Be prepared as in, there are times where, like you mentioned, sodium can do anything and can do it at any time. So we need to be prepared about what the issue is and where we need to take our loved one and what intervention do they really need. Sometimes in the care that we provide for a person with dementia, the aims are different. In the initial early stages of dementia, we treat the person to kind of hold on to their cognitive skills. We try and slow the neurodegeneration symptoms. In the moderate to severe, we try and help the caregivers. So sometimes when I treat dementia, I treat the person, but I see relief in the faces of the caregivers, that they say now we can definitely help our elderly really well. And during the last stages of dementia, where there is a lot of rigidity, and most of the times the patients are in a very moribund state and bedridden state, is where we would take away all the medications. We would just emphasize that the person has got to sleep well, eat well, and have good bladder bowel functions. But yeah, we need to sometimes, as mental health professionals, I tell all of these plans to my caregiver so that they are ready about what stage the senior citizen is, what ailments are we looking at, emergencies if at all there, what needs to be done in that scenario. And just after having a heart to heart with them, you'll be able to understand what they're really going through, what their problems are. I don't know who it was, but a great doctor is also who treats the person with the ailment, is what I think. Was it William Osler? I'm not very sure who it was, or Hutchison. I'm not sure. Somebody might just enlighten me. But yeah, the fifth caveat after being prepared is to be flexible. If at all they can't do a task, if at all they can't perform a task, do not test them. Do not ask them to perform it repetitively, or hit your head against the wall. Take a back seat, be cool, be calm, do not engage in any kind of discussion which might cause agitation, because the basis of the communication is for them to get what you're trying to say to them. So being flexible is the name of the game. And the last one is, as a person, firstly, do no harm. You yourself have to preserve your own sanity and preserve your own safety. And for a person, for a caregiver, to go through a last few days of their loved one is a very difficult task. And we generally understand that. We give them even venting sessions. Sometimes we allow them midnight phone calls, so that they can share their frustrations. There are certain caregiver groups which I conduct in person, where I would help them with, say, bureaus and different kind of caretakers who can come in and help their elderly. But all of these are certain principles which form like the foundation of a good caregiving activity for a person with dementia, or an elderly person.
Yeah, very apt, like very well said. And that was William Osler, by the way. The great doctor doesn't treat only the disease, but the
William,
patient. And so,
William Osler.
I really liked when you, like the way you said that You should ask them that what exactly, you should sit together, have a heart to heart, and ask them that what exactly is your challenge. Many of us just assume that we know what they are going through, and we
Yeah.
but many a times we don't know what exactly the problem is. So at least in my practice, the caregiver burnout is as high as 80 to 90% in patients on dialysis. I was just doing a like when I was reading for this, so in geriatric population also it's 60% above.
Yeah.
So it's very happy to know that you have caregiver support groups also. I would definitely refer some of my dialysis chronic caregivers, patients ke caregivers to you.
Yeah. Yeah.
So one thing which I try is that I ask them to switch roles, like especially for taking for dialysis, coming back, or doing peritoneal dialysis at home. So I make sure that there are 2 to 3 and they switch roles. But extremely important advice, especially about how we can share the burden by talking to them heart to heart. That's
Yeah.
a very very important advice. So we have Sonal, who is with us since very long time, but I could not identify her.
She was one plus.
And also Yosef has joined us. Hi, we have now two experts in the group. So
Hi,
happy to
Yosef. Welcome.
meet everyone virtually here. So Sonal has a very important question. She's asking that she comes from Sion Hospital after a busy day, and after coming back home, how to interact with them, like how do you break the ice and how much to talk, how do you go about discussing their issues, whether you should probe in, like really tell me what is the problem, or you should let them come out with them. How far you push this conversation?
Right. Part of any problem solving technique is to identify what the problem is and then to approach it. So, identifying requires communication, and we need to approach the person with respect, with care, and talk to them about. So, if there is a routine which has been chalked out for the elderly, whatever time you are entering the home, you know exactly what's supposed to be happening for them at that moment. And if there is a deviation in the mood, if there is a deviation in the activity level of the elderly, you'll be able to understand what might have happened. You might be able to even guess. There can be a phone call which people from home, or a message which people from home, whoever are observing, can send you, so that you get to understand what has been happening, what has been cooking at home. But approaching them to ask them about what's been ailing them is a very uphill task. It's not a very easy task. Hence, I mentioned that preserve your sanity is the first caveat, very important. But yeah, anything which has been asked with respect, with care, will be met with that kind of a response. And like I said, have to normalize difficulties. It's okay to make this kind of error. This can happen. It's a natural tendency for us, because we as clinicians have our time, so much of our time has been given to our patients and to other people's as families. So we are exhausted when we return back home. It's not very easy to be gentle or to be kind to our loved ones. But do understand that, generally what we tell to our caregivers is the receipt of your caregiving will be given to you by your next generation. So you are setting a precedent for your next generation as well. So when you're talking to the seniors, do understand that what Divya also mentioned. Imagine that you're talking to yourself, and how would you want to talk to yourself at the end of whatever. So you are there, and the person has missed you or something like that. So be kind, be very warm and gentle, and do understand what the problem is. After you understand the problem, list out all the various solutions. So for me, problem solving alternatives can be, so for example, if I have to go from my clinic to my home, I would list out all. This is the problem statement. The solutions can be: I can drive, I can take a rake, I can walk, I can even fly. So जो भी solution है list out करो. What is the most feasible one? Pick one of those and start implementing. you can identify, like I said, always have a team ready. There are family members, there are caretakers, there are doctors who are supposed to be at the core of this so that the burden is shared. For all the clinicians here, I will also say that there are various questionnaires about caregiver burden, which are translated into Hindi, Marathi also, which you can have, delivered to the relatives. They can mark it, and you'll be able to understand what they've been going through and how overwhelming it might just be for them. And sometimes you can yourself go through, because they are subjective questionnaires, you can yourself go through something like that. Yelling or getting angry with our seniors generally would be a very bad bad idea, because it ruins our day, and we generally then go back to and have a guilty conscience as to who did I raise my voice on, why, what was the need to be so agitated with them. So yeah, I think, yeah, Joseph has a question. Yeah, Joseph, go ahead.
Or he has a
Pratik,
comment. It's an answer.
Pratik, sorry,
Uh,
sorry. Should I
yeah,
disturb
Yes, please,
before
please
yourself start?
Bolo.
join in. Anyone who's more
Uh,
most welcome. Yeah.
hi Pratik. Hi Divya. Actually, thanks for the clarification. But fortunately, at present, all my elderlies are maintained and doesn't have any problems. My issue is that, see, as Divya said, when you go to the house after a heavy work day, and they're sitting, you smile, you talk for a minute or two or 5 or 10 minutes, and then you go to your room and rest. But then sometimes that guilty conscience come down to your on yourself. Array, what I'm doing, they're sitting outside, I'm resting inside. And then you come out and you want to talk, but then there are no topics at all. That's why I said it is a stupid question. I
No,
don't know
no,
whether
no,
this
no,
is happening with me only or this happens
no,
with
no, no.
everybody. I really don't know
Happens with
about it. But
everybody.
I
Happens
do
with
try to
everybody.
talk. As you all know, I am a chatterbox. I do try to talk, but still sometimes I feel I'm not giving enough. My in-laws are very good. I talk with them a lot. We have a laugh and everything. We joke around and everything. But sometimes I feel that. Are there any things that we should be looking after in a daily conversation? Now I'm getting enlightened with your conversation, so I will be more careful henceforth. But still, a tip, one or two tip will be helpful. In a normal
So,
individuals who are not having any problem at present, they are just
no,
elderly, nothing else.
so like I said,
Successful aging.
your family members will be as good as you. And if you are taking care of yourself, do understand that you are taking care of them as well. It's not just a very selfish act of not speaking with them. It can't be done with a reductionistic approach. म्हणजे, we can't go down to saying that, okay, we are absolutely not caring for them because we are caring for us. And like I said, the first caveat is always sanity. Preserve your own sanity. Whatever helps you will help them as well. And see, they were in your role at one time as well. For your grandparents, they have done the caregiving, or they have been the sons and the daughters. So you can even talk about how difficult it is to be a clinician, and come back home with a different mood, or a lot of stress in your mind. Joseph had raised the hand. Joseph, you wanted to say something, or question, or whatever. Go ahead.
yeah, I just wanted to add something. One is one mnemonic I would like to give everyone, which give in our therapy. Pratik, you might be aware of that. It's used in DBT. That is mnemonic that we use when we have our relationship with others or try to behave in a certain manner with others. Is give, GIVE. So G is to be gentle. Try to be gentle, as Pratik said. Second is I is interested. Uh, Sound interested, be interested, and listen to what they actually have to say to you, what they mean by whatever they say. There might be sometimes passive aggression, there might be love, there might be care. a lot of things, right? You will understand when you are interested in it. V is validate. Try and validate their emotions, because in elderly there'll be rigidity in their personality. If you try to cross them, then this dialogue is always going to come. मला तुझ्यापेक्षा जास्त कळतं, तुझ्यापेक्षा मी
Hmm.
जास्त पावसाळे खाल्लेत. Right. So there'll be dialogues coming like this. So try and validate their emotions first before giving any contradiction or any opinion of yourself. And third one is try a easy manner. Find out a easy way out to talk to them. I always say to any of my clients who come to me who are frustrated or who are burnt out because of elderly care is try and understand your personality first, right? Like Pratik rightly said, ki try and preserve your sanity. It means try and give yourself your me time. We've been doctors, we see so many patients around, we sometimes are frustrated. We need to check our personality and check the things that we can modify in our personality. One. Second, understand the personality of your elderly. The elderly might be your in-law, elderly might be your own parent or something like that, right? Try and understand that person's personality as well. That person might be short-tempered, might be too caring, but the way they express their emotions might not be rational slash helpful or unhelpful. So try and understand their personality as well. And yes, try and take out time for yourself. Try and identify your emotions for that day at the end of the day before you enter the house, right? And follow this mnemonic if you can. And maybe that will help you out. Yeah. Thank you. That's it.
Thank
Thanks,
you,
Joseph.
Joseph.
It's a very useful mnemonic and a very useful advice. I'm sure everyone would follow that from now on. And like I firmly believe that you can't pour from an empty cup. So
Yeah.
if you are not at peace, if you are not in a good mental health, you will be transferring that same vibes, energy to everyone whom you interact. So we should be definitely taking care of ourselves with whatever we can, how much we can connect, and how much healthy we can keep our mind before taking care of our elderly patients and family members. And
Yeah,
like
I always tell them, I'm sorry. I'm
yes,
sorry,
please.
I'm cutting you. Uh,
No, no.
I always give them example of whenever you sit in an aeroplane, the air hostess gives you instructions, right? जब भी वो मास्क नीचे आ जाए पहले खुद का मास्क लगाओ फिर साइड वालों को लो. Sonal, you feeling guilty? I understand that. Even a lot of times, a lot of us go through this. But then yes, पहला खुद का मास्क लगाओ फिर उनके मास्क लगाने की कोशिश करो. Yeah.
Yeah, Faraz, you have a good question. Would you mind unmuting and asking it yourself? We want to have this interactive. Faraz, you're there? So Faraz wants to know. Sorry.
Ah,
Okay, for
the mic is
mic is
not
not
on.
working. What are the solutions? So we have elderly with chronic illness, maybe cardiac, COPD, DCMP, CKD, and then they what routine we should establish for them? What activities we should be insisting, even though if they deny doing those activities. So what are the
Right.
solutions or routines which we should be establishing for these elderly patients, especially with chronic illnesses?
So, this answer can be also used for the question, what can we do to prevent dementia in ourselves? Or,
Yes.
promote good memory or good mental health in
Yeah,
anyone
that was
in
the
the
next
family.
question. Yeah. Thanks,
So,
Faraz, for to bringing it early.
absolutely, nailing the question. So,
Yeah.
four activities that we need to do. First activity is a social activity. We must ask our family members, whoever is in the senior citizen age group, to socialize at least once every week for at least half an hour, 45 minutes time span. There are nana nani dada dadi parks everywhere. There are laughter clubs in so many societies, in so many small areas of housing societies as well. There are yoga groups, there are Brahma Kumari groups, and art of living, any other place where people can socialize. Something which promotes good memory. Now, memory is also about registration and recall. So, if I meet a friend of mine today, I ask them about the thing that they had told me in the last meeting. So I have to retrieve an encoded memory and say it out loud, saying that, okay, you tell me about the last thing, what you were saying last time. How is it right now? And my friend also gives me new information which I encode and then I store just to be retrieved back again the next time. So social activities are the name of the game when it's about preserving memory. We have a therapy called as reminiscence therapy. In this kind of a therapy, we sit down with with our seniors, we sit down with them to reminisce about the olden times, as in their jobs, the special days in their life, any memorable trips that have been there, any particular activity, their special days. So if they had won any awards or any kind of really highlights, we go over them, and this is exactly something which preserves their memory, because in dementia, the first memory to go is the recent memory. So say for example, if I ask my patient that what have you had in your lunch today, or in dinner last night, that is recent memory. Remote memory, which is autobiographical information, is usually preserved. So for revising a recent memory, we need to have conversations with our elderly. We need to talk to them about their routines. Routines start from a time of getting up to maybe a morning meditative or a spiritual or a religious activity, to breakfast, to maybe something which is a very personal nature activity, which can be reading, which can be watching the television or interacting with the grandchildren, looking after businesses or any small ventures that they might be having. Evening should be compulsorily one meal every all the family members are supposed to have with each other, just to talk about their day. And then maybe after that, everybody can retire for sleep, and there is a fixed time to sleep as well. So first is social activity. Second is called spiritual activity. Now, it's necessary sometimes to understand that it's okay. As in, I won't force this upon anybody. To each or her his or her own. But spirituality or religiosity has been a great go-to for the baby boomer generation, and they believe in higher powers. They are inclined towards it. So if we ask them to engage in these kind of activities, they boost the morale. They sometimes give meaning to a person's life, and they also, are associated with socialization. So these are certain things which boost a memory of a person. Third is a cognitive activity. After spiritual, cognitive activity. Cognitive activity can be anything which taxes their memory, which asks them to retrieve information and code new one. So even a simple karaoke, which is the rage these days. All the mummies and papas want to sit and sing duets. So, karaoke's, sudokus, crosswords, card games, board games, even video games. If they're cool with it, and if they're really, tech savvy, you can sit down, even play with that. If a person is asked, so if they are right-handed, and if we ask them to eat via through their left hand with a spoon or something like that, so there is neuronal plasticity, so newer connections are formed. We can ourselves. I've seen this one video. I don't know if she's there, Neha Bansal. I saw her dance with her mother in one video. So helping them express through dance, through music, by learning a new instrument, by doing a recipe. I know my dad comes into the kitchen these days, and he cooks also. So learning something new is the name of the game, and it's very important. so that there are newer memory formations, and at the same time, the cognitive decline is somehow checked. So that is the cognitive activity, and last is physical activity. 30 minutes of walking every day for 5 days, so 150 minutes every week is something which has been mandated. And so these come in our guidelines. So Indian Psychiatric Society, which I think even Yosef is a member of, and they have issued the guidelines since a long time. But a little bit of a physical activity doesn't harm anyone, and helps with all the cognitive processes, helps with keeping diabetes in check, hypertension in check, depression in check, all of that. So helping them, so like I said, in the morning routines, having some physical activity planned for them is very nice. I don't know if India has Tai Chi, but Tai Chi is one exercise and one method of meditation also to certain extent, and yoga, of course, which has had a lot of evidence to its name about cognition, to preserve cognition. So social activity, spiritual activity, cognitive activity, and physical activity, four activities that we need to incorporate in their day, in our days, to prevent dementia, to maintain good memories. So yeah, that's that. Divya, I think the mic.
Yeah. Yeah, so my daughter was around, so I muted myself for some time, but super helpful. It's not only for elderly, it's actually helpful for us also. Like I
Yeah.
also feel that I don't know, I'm forgetting things more now with time. So very, very helpful advice. And I'm sure all of us will stick to that. So Nazim has joined us. Hi Nazim, we are having a wonderful time here. We have gone through a lot of useful issues over. We have now so just a recap of in last one hour 10 minutes we have done epidemio. We have looked at how successful aging is, what is dementia, pseudo dementia, delirium. We have looked at depression, we have looked at dementia danger signs, anxiety in elderly, how do we differentiate that from a normal behavior. So it is my duty, and actually they are very important questions. We have questions from our group, from our fellow friends who have asked us very specific and very important things. So actually they come from two different friends of us. We'll maintain the anonymity, but both of them have little bit common things. So you know, not every one of us are blessed with a very good relationship with our parents. Growing up, we have had it's very normal to have had issues. Maybe there are some things about their behavior which we have not liked, or our behavior which they have not liked. So there it is possible that we have some resentment, some anger, some hatred. It is
Yeah.
like the time have passed and like bygones are bygones, but then those things can come up in our relationship now also. So how do we move past that? And sometimes so that is one part of the question, and a follow up of that question is sometimes our senior members, maybe it can be in-laws or parents, they're very critical of our actions. Like we have critical appraisal of every research article published, we have critical appraisal of each of us daily at home, maybe from in-laws and from our own parents. There's nothing
Yeah.
specific in that. Everyone can be critical. So how do we move past the past resentment, and what do we do when they get very critical of our actions today? Specifically, I want to talk about the disputes which can happen with relation to child care. Like, I
Yeah.
want my daughter to grow up in a particular way, and my mom and my mother-in-law gang up together, and they want something else for my daughter. So that is a constant little bit point of resentment. So past issues, present issues, disputes, how do we go about it?
Um, One thing has to be established: parents are the bosses, no doubt about that. Yeah, and has to be established by both the parents, for the grandparents. Grandparents का काम है, they have to give love of the language, they have to give religious inclinations, spiritual inclinations. They have to give some amount of sense of right and wrong for the kid. They have to engage the children in fantasy thinking as well. That is their job. So they have a pretty loaded repertoire of different tasks that they got to do. But one thing has to be established, that the parents are the bosses. No two ways about it. Generally, where there are differences between parents and grandparents is allowing carbohydrates, so basically about nutrition, and screen time. These are like the point of absolute screaming matches sometimes, which have happened between parents and grandparents. But if there is resentment, if there is hatred, if you see them minimally, if you see your parents minimal, that's also okay. Nothing has to be forced, and nothing has to be imposed upon. Like I said, it's a teamwork, so you can have another family member check up on them. You can address your concerns with the general physicians who's checking up on your parents. You can take feedbacks from them as well. If at all the relationship is not that great, or you're not living with them, anybody, this is not about just one person. But when they are critical about your parenting, you have to have rationale behind everything. So you have to give your rationale to them, hoping that they understand that. But it's your child. They had their shot, and they have done a great job. Tell them that, but ask them to, request them to, back off, necessarily back off. It is your playground. It's not theirs right now. But like I said, they have a big task to do, to for the kid as well.
What about past resentments? Like if we
Yeah.
have had not very good relationship, like one of our group members had that problem. So, but
Right.
now she really wants to care about the parents, but then those past things keep on coming to her. So, what do we do about those?
Sometimes if moving ahead becomes very difficult and these kind of issues keep on disrupting the relationship, it's nice to talk with the therapist. It's nice to take it up with mental health professionals. Maybe even see that you can take your parent alongside with you, so that there is a concept called as family therapy also, that we as mental health professionals do, wherein we take up even about communication patterns with our elderly. So how do we communicate? What's the equation like? What has been there in the past? Now, when a third person comes into the scenario and establishes objectivity, sometimes both the parties understand each other well. So, in case ever there are disputes which are so disruptive that communication just doesn't happen, my phone number is there. I can definitely share anytime. Any mental health professional anywhere in your city, in anybody's nearby place, they are trained to go through. Now, thanks to COVID, I know Karuna is practicing teleradiology, so we are practicing telepsychiatry as well. And we can intervene even through Zoom calls. We can intervene through WhatsApp video calls. Nazim has a question. Go ahead, Nazim.
Yeah. Yes, please, Nazim. So we have Pratik, Yosef, we have Rupesh. We are lucky to have all of you whenever you are just phone call away. Thank you so much.
Oh yeah.
Yes, Nazim, please.
Thanks. Yeah, thanks, guys. Thanks, Divya and Pratik. You're doing a great job. Just a small, just you mentioned about important of fantasies for children. So just a small bit on that. I mean, it's off topic, so I don't want you to go, in details about that. Secondly, another thing was that what is the support system that we have in India? I want to ask it as a question to all the, especially a lot of us are staying away from our parents. So the support system, we have for our parents in India, apart from the social and everything, and how important is the health insurance as of now in considering the current scenario for our parents. And thirdly, most important, yes, I'm glad that I remember it now, is the sleep disturbances. I don't know if you guys talked about it. I'm sorry if you guys have already talked about it. It's a very common problem in
Yes.
the elderlies, and especially my I, I can if I can be a little honest, मतलब मेरी माँ बहुत टाइम से इस चीज को फेस कर रही है, like it must
Yeah.
be
Yeah.
around 10 to 15 years. So
Yeah.
what are
Yes.
the how can we put them on long term this thing, SSRIs or other thing, or because physical, or just is it just physical activity, or how does it work? Yeah, thank you, please go ahead.
Yeah, thanks, Nazim, for that question. So, when I say fantasies is like my grandmother had told me Mahabharata stories. She has told me Krishna stories where Krishna opens his mouth and his mother can see the whole Brahmand in it. So many of those stories. And children are developing, like imagination. That is something which grandparents are absolutely skilled to do, something which even they are looking forward to do. Giving them their grandchildren, but with a caveat that parenting will be done by me. But that's somehow necessary. Second thing you mentioned about insurance and how to support. Now there are bureaus here in India. Particularly, I speak about Mumbai city since I'm aware of this. Bina Bureau, Care 24, Aji Care. These are three bureaus, and there is an initiative called as Echoing Healthy Aging. This is from a person who's a master in dementia care management. Her name is Amrita Pimple. They have some good programs for cognitive activities and cognitive retraining for our elderly senior citizens, but at the same time they provide trained caretakers. So it's worth its weight in gold. If you have someone who has been there for some other person who's elderly and insurance, I think Sachin Gaikwad will be the best person to go to. He had even mentioned that he wanted to do a podcast for that. So we'll look out for that. I won't be an expert in that area, but caretakers is something I think people need to be open towards. Now, third thing, Nazmuddin, let me make you comfortable there. I think uh, my parents, my in-laws as well, they have sleep issues, and I've had them consult my senior colleagues for their sleep issues. So it's been close to 20 years now that both the sets of parents have been going through something like this. No particular reason for that, but yeah, the medication can be decided on an individual basis. I would still say that yes, theoretically, benzodiazepines do come with the risk of, say, memory loss or something like that. But we have to always got to do cost benefit analysis for every medication that we prescribe. And if we see the benefit and it outweighs the costs, even a benzodiazepine won't do any harm. Having said that, in our elderly, we generally refrain from prescribing benzodiazepines because they can themselves cause delirium or spells of confusion. So there are medications available now which affect melatonin is also good. Yes, melatonin is also being used. Sonal, thank you. Melatonin again is something which has been right now used from 3 milligrams preparations to 10 milligram preparations for our senior elderly population. But yeah, for sleep, treatments have to be given, and it just doesn't happen through yoga or spirituality or physical activity. Sometimes they require help. As it is with aging, the sleep schedule changes. So if this was a person sleeping from 11 till 6, they sleep from 9 p.m. to 3 to 4 a.m. and they wake up at 4 a.m. And when they are up, the whole home sometimes has to be up, depending on how they are functioning in the home. But resetting of the sleep cycle, has it generally happens in this elderly, and no harm in getting them interventions which are even benzodiazepine based. Yosef, is there anything that you'd want to add to what Nazim asked? Any particular other medication or any other modality?
Uh, Lamborghini I use quite often
Yeah, yeah.
for
Lamborghini
sleep.
is another one. Yes.
Yeah.
Yes, Nazim, I think there is anxiety the next day that has been seen, and in that scenario, like I said, individualizing the treatment there, maybe an SSRI can help there. What Yosef also mentioned is a new medication which works through orexins. It's called lamborexant, and is a wonderful medication with regards to sleep disorders, particularly in the elderly population, very minimal effect on memory, or doesn't produce confusion. After melatonin, we are preferring that medication these days. But having said that, whenever nothing works, benzo works. So that's something I won't bullshit anybody about. Use of a benzodiazepine.
Yes.
It's one of the modalities.
It is, yeah. So, just one word of caution from the nephrologist on board. Lots of psychoactive drugs are excreted by kidneys, something as benign as pregabalin. It's not a psychoactive drug at all. Gabapentin, tramadol given for pain, because you don't give NSAID, you get this. They make these patients, kidney disease patients, very drowsy,
Yeah,
like really drowsy. They have had falls, and
false.
which we want to actually ask Pratik next. Falls are a very important thing. So just look at the kidney function when you are prescribing any drug. That's just a word of, and look at sodium before making any diagnosis. Anything related to behavior, look at sodium. That's just a word of caution. So coming to falls. Yeah, thanks. Coming to falls, so I was discussing my grandma, Pratik. She was 93
Yeah,
when she left us. Her,
sorry
she
for your
was
loss.
like, she was a professor, very smart, very successful aging, and no dementia, and everything was perfect. The day she had a fall and a fracture femur, and she
Yeah,
was bedridden for almost 3 months, and it was such a big u-turn in her aging, like that successful aging completely
yeah, yeah.
tipped off. And
Yes,
when, because she was bedridden, she was having this guilt of being cared for by someone else. Privacy was not
yes,
maintained because we had
yes.
to keep a 24-hour maid.
Correct.
She could not, she was so upset that she can't go to loo on her own. And
Yes,
then she somehow got hi hi she got very depressed that she is now bedridden, and then she was desensitized. Even when her bones
yeah,
became normal,
yeah,
she could not move the way she was for three
yeah,
four months
yeah,
downhill. So
yeah.
fall was a big turning point for her in her aging process. So I really want to know. I know, I have published on this that sodium hyponatremia causes fall. It changes bone density. Apart from that, please tell us something how to prevent them.
Right. So, with regards to falls also, I think one of the reasons why we lose persons with dementia, one of the reasons is falls, and after which there might be pulmonary thromboembolism, which we've seen, or aspiration pneumonia. These are two, but falls we need to prevent in our elderly for various reasons, and there can be um, multiple etiologies as to why a person might go through fall. But Divya, you mentioned about the successful aging and what happened in the case of your grandmother. Sometimes, dementia is unmasked by, say, a person went for a dental treatment, received anesthesia, and suddenly, the successful aging got turned into a dementia kind of a picture. Change of residence, complete change of residence also sometimes gives rise to confusion, like even to the point where they become, and this is something which is worrisome, because they wander off very easily, and we have seen that senior citizens go missing sometimes because they have gone out in the search of their own homes because they can't register that the home that they stay in is their own and the people who stay in that home are their own. But yeah, preventing falls, we need to firstly identify what is causing, or what is the factor which is associated with it. To reduce fall frequency, we need to take a drug review as to what medication the person is on, and if there are any medications which cause dizziness or orthostatic hypotension. And again, like I said, it's a teamwork. So GPs and the specialists have a task that they need to identify these kind of issues. Having said that, occupational therapy is one therapy which is underused for our senior citizens. We Yeah, Nazim, you wanted to say something. Please go ahead. Oh, पहले का था. Can I continue, or Nazim, you had a question?
Yeah, hello.
Sorry. Yeah, go ahead.
Yeah, I'll just want to weigh in on from orthopedic point of view. Just quick points. First, it's very important to have a good muscle mass to support to
Yes.
have a good balance. So, and that muscle mass would come from your early 40s and 50s and 50, 60s. Once you are past that age, to gain a good muscle mass to control balance is a bit difficult. So to
Yeah.
prepare for a good aging, you have to prepare like way early, decades ago. uh,
Yes.
uh, that's why the whole concept of longevity has come in like in a very big way these days. We have like a brain performance center in Dubai, where they were using hyperbaric chambers, and that was from the brain point of view. I'm digressing, but from the orthopedic point of view, um, vitamin first is muscle strength, which can be built
Yes.
in the early 40s, 50s, 60s, in the early elderly age. I don't know how to put that. Then vitamin D has shown some benefits in improving not only bone density but also muscle health. So there's a lot of research going on, but the vitamin D also helps in building your muscle
Yeah.
strength and the
Yeah.
and the muscle response. And thirdly, few months ago, Aditya Yadav, in our batchment, he mentioned that we should we should put a lot of anti-slip. What is it called? Anti-slip mats in the bathrooms.
Mats. Yeah.
Yeah,
Yes.
because bathroom falling in the bathroom is a very common thing, and we should equip the walls with some sort of an handle so that they, in case of a fall, unfortunate fall, someone can catch on to it. So yeah,
Yeah.
that's all. Please continue.
I had some photos also which I'll show with regards to what can be used in home, so that we can ensure safety of our elderly. मैं screen share करूँगा, and then maybe we can see.
Yes,
But
please.
uh, we can prevent falls. Say what Nazim also mentioned. Identifying people with osteoporosis and treating that, so that the bone health has to be great. We can even have physiotherapy professionals physiotherapists coming into the home, or we taking our elderly to increase their muscle strengths, and even the joint health. Sometimes even teaching patients how to get up can help, and physiotherapists can help even in that. Uh, Installing alarms, maybe even having supervisors or caretakers, like I mentioned, to kind of assist them in moving around. Of course, there can be usage of walkers, of wheelchairs. Generally, people have apprehension that a wheelchair would cause dependency on the wheelchair. It is something which I've seen and I heard in my clinics, but actually, it is the comfort of that person that is the most important. What you think might be right for them it is not the best way to go about it. We need to somehow individualize, we need to somehow empathize with what they want, and then sometimes even go for that option. But yeah, autists can come into the home and optimize the environment. So I'll share a few photos of what I mean by optimize, and what can help assist us and our elderly. Just a minute.
Yeah, please. It's very, very important, especially like for my patients, chronic kidney disease. I'm sure Nazim must be seeing them also. We have like really poor bone health. They have hyperpara, they have osteoporosis, osteomalacia, you name and they have it.
Yeah.
So it's also a reminder for us, like us at this age, to start taking care of our bone health, muscle strength, to prevent falls in the elderly.
Okay, okay. Is it okay if I share it in the
Yes,
WTF
please.
group?
Yeah, yeah,
Because I think
that,
the only the
yes.
host can make this
Yeah, okay. Neha is not with us, so I think you
no, no,
can
no.
share with us in
Yeah,
that.
yeah, 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 absolutely. So
Sonal wants to know, Prateek, that benzodiazepines, which we give for sleep, which is like this is the last resort, whether
yeah.
they will also be like culprit in causing falls.
Yeah, yeah, they can also be, but
Yeah.
like I said, the assessments have to be done and follow-ups have to be taken with the mental health professionals who have prescribed it. What we've seen is like a thorough physical examination rules out, and we can address so many concerns that senior citizens have. So even training them in getting up slowly from the bed, is something which I do very frequently in my clinics. These are simpler measures to prevent a fall. Now, what I've shared on the group, if people can see, so the first one is called a banana board. So this is a apparatus used in moving a person horizontally. If ever we are shifting a person in our home, we can use this kind of an apparatus to prevent a fall or to prevent there can be other measures as well, but this can be used very easily by all the family members. This is in the WTF group that I've posted photos. um can everyone see that? Oh yeah, great. Yeah, that the yellow one, the one which, yeah. So different kinds of those. So yeah, for helping the person shift horizontally, even if this is a pretty healthy or overweight obese person, we can shift them easily using this board. The next is transporting our elderly, even in a scenario with hip fractures, or so this is called a swivel seat cushion, which rotates on its own, so that we can shift them, and definitely easier to bring them out of the car, bring them out of the seat, using this kind of a cushion which rotates around an axis. Third one is called a perching stool. Now, this is something where the height can be changed. Now, these are for the ammas and ayis and the mummies who want to continue cooking, who want to continue supervising in the kitchen, but have some kind of movement issues or weaknesses in the muscles, where the height of this the stool can be varied, and they can do all the activities that they were doing earlier as well. So these are certain things which I just wanted to mention. Of course, walkers and walking sticks are these days of different varieties, and we can definitely choose one which helps the elderly move around in the home so that they are supported. But see, regardless of all of this, it is possible that the fall might still be there. We can eliminate all kinds of risks, but it is still very complex as to what eventually causes. So, Divya, I just want to share my grandmother, my dadi. She was a person with dementia, and she is the fall happened during COVID first wave, and there were very few people who could make the visit, or even for X-ray we had to struggle a little bit with her because she was a person with dementia, and eventually we had to not intervene, and we chose palliative and to let her go. But the fall was, like I was sitting just in the room, just a little few many meters behind her, and the caretaker was taking her to the washroom, and she just fell down. The muscles were very weak, and she just fell down, and nothing could be done in that scenario. But still, we need to make sure that we have these kind of measures with us, so that they are very much involved in the household. We can transport them safely in the home or in through the car, and wherever we are taking them. Having said that, the walkers also come with sometimes with wheels attached to them, so that you can take it over roads, or ubad khabad wala rasta bhi hai agar, it will still move on that surface. So, these are some of the measures which we can definitely employ to minimize falls.
Yeah, and Nazim has a very important point that postmenopausal BMD is bone mineral density is directly proportional to premenopausal activity level, and whatever
Right. Yeah.
we do now, we pay for it later. So that is a very important thing. Just one word, like Nazim had also asked, and we were discussing, and you had brought this. So we have a very good palliative care groups now in the city of Mumbai.
Yeah.
I work in KM, and we are across the road from Tata Memorial
Tata.
Hospital. So nowadays cancer patients are living
Yeah.
a much
Yeah.
better, healthier life, but
Yes.
they some of them
Yes.
still need palliative care. Also non-oncology palliative care is also is like coming up very, very
Correct.
strongly. I am a
Correct.
part of palliative nephrology care society, where we there are patients who we don't feel will benefit any longer from dialysis, and
Yeah.
then we
Yeah.
choose to keep them on palliative rather than giving them more suffering by
Yeah.
going ahead with aggressive dialysis. So one such institute, or like one such group I know of, is Sukun Nilaya. It's
Correct.
situated, I think it's around Saifi Hospital. It's there.
Mm-hmm.
And they have like state of art palliative care facilities, and
Yeah.
that's completely free of charge. I don't know how they're some trust or kind of thing, which with which they run it, but very good, free of charge, and very well trained palliative care physicians are there. So
Right.
that's another realm altogether. So I think we are at the tail end of our this discussion. Pratik has done a wonderful job holding our hands, getting us through this. So I would like to invite closing remarks from Pratik and also from Yosef. We would like to hear from both of you, please.
Uh, Joseph, if you could go before me, because I'll end up, cracking a joke which I have here.
I
It's been a
wanted to
very
ask a
serious
question,
session,
Pratik.
and it's been a serious session. So I would want to end on a lighter note. Are Atish is there? Atish, yeah, go ahead. Hi.
I wanted to ask one
Hi.
question, Pratik. Luckily,
Yeah,
we
go
are
ahead.
having this session recently, and yesterday only got a call from my school teacher. She is a patient of poliomyelitis. Very extraordinary teacher, very good command on English language, and she was overachiever all her life. Now she's a retired, and yesterday she shocked me when she asked me she wants to inquire about body donation, one, and also about euthanasia.
Euthanasia. Okay.
So I asked her to get evaluated for the depression. She knows about it. She says, no, I don't have any other, I know it is not like that, but I am feeling myself burdened over my family, and I feel like I'm fulfilled. How to answer such things and how to convince them to go to seek professional help? Thank you.
Sometimes the professional help should come home. That is something which is very effective, because moving around is, as it is, a very big task for the person. There are, so this is in Latur, Atish. The person is in Latur, I
Yes,
think. Yeah.
yes. Person is in
Yeah,
Latur.
I can send you references of people who can make a home visit and care for her there, because sometimes all we need to give is a little bit of hope, and that is sometimes enough for a person with depression. uh, I wanted to mention this while we were talking about depression as well. So the dosages of antidepressants or any sedatives medication that we give in the elderly are very minimal. We start at a very so it's like start low and go slow is the dictum that we follow, and the dosages required are very, very low dosages, and they respond really well. and it's all about the quality of life of that person. So something which that lady mentioned also struck a chord with me, Atish. I think euthanasia is something which is very relevant, and it's a topic where if we are in the mood, pros and cons do sometimes
Mm.
go through
It
revisions.
was, it was a googly question. I could not answer. I could not say no and yes to,
Absolutely.
because I know
But
what he is going through.
uh, what a lovely student you are, man. You're still in touch with your teacher and you're looking forward to
I
helping her.
also felt blessed that she felt so open. She didn't open up
Yeah,
to her
yeah,
son, and she called me and she told me,
absolutely
I think I
wonderful.
have this query. I
No,
said
no,
I'll ask the
wonderful.
expert. Luckily, I have a session.
Wonderful, wonderful. No, no, no. Care will
Thanks.
be provided.
Thanks.
I'll make
That's
sure that
really a
that
big
care is
thing,
provided to
Ashish.
her.
That's a big
Thanks.
achievement for teacher calling you for this. That's a
Yeah,
really big
yeah.
thing.
I know. I know.
Oh,
Seriously, Divya, I felt blessed. Yeah.
So,
Thanks.
like in my limited knowledge, active euthanasia is still illegal in our country, but passive euthanasia, like
DNR
means active is like you're causing death, but passive is you're only withdrawing support,
support.
withdrawing life support. So that I think with some very strict guidelines from Supreme Court, that has been given some permission in some specific cases. But then, uh, once her depression is cured, do talk to her about organ donation. If she has thought about it, it's a
Yeah,
very noble
yeah,
thing.
yeah, yeah, yeah.
Rather
Yes. Yes.
than body
I
donation,
told her.
organ
I
donation.
told her.
Yeah, that is something. And maybe you can give her more hope by saying like, even after your death, your organs will keep on living. That's a very hopeful thing. There's nothing
Beautiful.
negative about it.
Absolutely.
Yes, yes.
Absolutely. Thanks.
So, Yosef, we are waiting to listen to you.
Closing statements.
Yes.
Yeah, it doesn't feel fair to, say something wherein I was there only for like I think the half or one third of the time. Pratik, I'm sure he has covered everything about elderly care. I would like to say that elderly care is complex, not easy, I must say. Instead of putting it as difficult, not easy, and it will take patience. And all of us, we need to be aware of how elderly care is given from both mental health point of view and physical health point of view, and balance between our mental health and their mental health as well. And thank you very much for this Zoom meetings and podcast series. Thank you, I must say, to Pratik, who has been very active in the group and pushing all of us for this such sessions. Although I was not able to attend the previous sessions because the Zoom meetings were in morning and I had to attend church. But yeah, I'm very happy. I feel blessed. I feel more knowledgeable now listening to what Pratik has said. There were few things which I think my neural circuits have forgotten, which were refreshed. Thank you very much, Pratik. Thank you for all participants who were
Correct.
there. Thank you, Divya, for this initiative. And I'll surely be joining for the next sessions as well. Yeah, thank
Great.
you.
Thank you, Yusuf. Very humble of you, and thank you for being amongst the people who attended. Very encouraging to have friends and contemporaries attend anything that you are doing. So we come to the end of our discussion, and this is a very great joke set, by Woody Allen, who's a very famous stand-up comedian and a very amazing director. I would advise anybody and everybody to watch a movie called as Annie Hall by this person, and it's a 1970s movie but very funny. So the joke goes, so it's a quote from him. He says, "In my next life, I want to live my life backwards. You start out dead and get that out of the way. Then you wake up in an old people's home feeling better every day. You get kicked out for being too healthy, go collect your pension, and then watch you start work. You get a gold watch and a party on your very first day. You work for 40 years until you are young enough to enjoy your retirement. You party, drink alcohol, and are generally promiscuous. Then you are ready for high school. You then go to primary school, you become a kid, you play. You have no responsibilities, you become a baby until you are born, and then you spend your last 9 months floating in a luxurious spa like condition with central heating and room service on tap, large quarters every day, and then voila, you finish off as an orgasm. so, so this is something which he had summed, and I think for our elderly care, lecture, I just wanted to end on a very lighter note. So yeah, that is.
Thanks, Pratik. That was awesome. That was really, really very good. And thank you so much for taking out the time. Like everyone was, we have been like lots of people were thinking of doing it, and like we'll have a Zoom meeting someday. But then you are a doer, and like you actually started this, materialized it. I am sure you must be very busy, like all of us are, in your daily life. But you took out some time for us. It feels so good to have such supportive friends, and it feels so good to connect with all of you, Sonal, and everyone virtually. And we could hear everyone, each of us. It was a wonderful time. Anyone would like to say anything? Atish has suggested a movie,
Yeah.
Still Alice.
Still Alice, and
We'll definitely go.
there is a Marathi movie called as Astu. There is an English movie which is called Father. Again, Father is from a dementia patient perspective. It's not for the faint-hearted. I kind of couldn't see that movie. Black again, very atypical, but yeah, a movie for portraying the person with dementia. Thanks, Atish. I'll go through Still Alice.
Thanks everyone.
Yeah, Anthony Hopkins movie. Yeah, yeah,
Anthony,
that's
yeah.
all right. So yeah, thanks, Ronak. Appreciate you attending this. Thanks, Sonal. Thanks, Atish. Both the
Thank
Sonals.
you so much, Pratik. As Divya said, you are the only doer, and you are doing this so much for us in spite of your busy schedule. It's
No,
really
thank you.
hats off to you. And thank you, Divya, for moderating. We would
Yeah,
like to
thanks,
hear
Divya.
from you
Absolutely.
as well regarding the kidney health, how to like protect our kidney when we are in our early, late 30s, or in some of us in just reached the 40s. So that would have been a best topic. So if Divya can do that as a podcast, if Pratik can support my uh, uh, view,
Definitely.
what do you think,
That
Pratik?
should
Definitely.
start from your childhood, you know. We should start off thinking of protecting our kids' kidneys also. Like it's
Yeah,
that
that
early.
I think I didn't had insight when I had a first born. During my second born, I tried my best, in spite of lot of hammering from my in-laws and parents. But still, Divya, it would be nice if you cover something like, won't be a 2 hour session. If it is possible for you, 45 minutes or 1 hour will also do. And Pratik, thank you so much. And if there are any further topics, please, for us, please try to take them and do a podcast. You are a very good speaker. And we would like Mansi also to join with you. She's also a wonderful speaker.
Thank you. And one more person who we should thank in all of this is Neha Bansal. She
Yes.
made this
Yeah,
all
yeah,
possible,
definitely.
and she's gonna put this up on YouTube soon. And thank you, Divya. I think it was really nice. This conversation, kind of a discussion, was very effortless. Thank you for being a lovely moderator. Thank you so much.
Thanks. Bye everyone. Have a great
Yeah,
night
yeah,
and
yeah, yeah.
Bye
remaining of the
bye.
weekend.
Divya, Divya, wait. My son wanted to say hi to you. Hey, wait, इकडे ये.
Hey, hi.
Hey, hi
Hi.
there.
Hi, Kanchan uncle.
How
Hey.
are you?
Say I'm fine.
कैसा है बच्चा?
I'm fine. He wanted to interrupt you and wanted to unmute every time he was seeing you. I said, oh, wait, we will talk with Divya auntie after the end. Hey, Veda, come here.
And
Say hi to Divya auntie.
Thank you.
ये कौन है? देखो देखो
अरे
देखो
वाह,
देखो.
हाय गार्गी.
Say hi to uncle.
ये आया तो छोटू था वेदू तभी. हाय वेदू.
Oh, hi, Didi. Hi, Gargi Didi. Hi. Hi.
All right.
Can you see my face?
Yeah, can see.
ये मेरा
Okay, so the
छोटा अंग्रेज है
meeting.
बाबा जो
Okay. So the meeting will get over once we all leave the meeting. So we all need to leave so that the meeting is closed.
Yeah.
Otherwise, it will keep on going.
So
Sorry,
we'll
guys.
leave now. Bye. Say
All
bye.
right. All right.